Hello and welcome to Gastro Learning Live. I'm George Webster, and it is an enormous pleasure to welcome my friend and colleague, Dr. Rehan Haidry, to take us through esophageal perforations. Now, one of my mentors once said that an expert is somebody who has seen every complication within their field. And actually, I think that is a really useful definition here. And Rehan certainly fits that description. Rehan, great to have you with us. For everybody, you know, when they're faced with an esophageal perforation, particularly if it's iatrogenic, you know, it gets the pulse racing. There's anxiety around it. Great to have you taking us through how we should be approaching this. But first, just a few comments about where you see the risks of perforation, and a little bit about the anatomy, because I think that you know, it's something that the less experienced endoscopist doesn't quite recognize the importance of the anatomy.
George, thank you very much. And, you know, first of all, just a very quick thank you to you and Dr. Graham. I'm a big fan of the Gastro Learning Live. You know, I often log on to watch. So much learning here. So thank you for having me. And, you know, this is a really, really important topic. So just, you know, there's a couple of questions. I think, you know, esophageal perforations are by far the most common, you know, luminal complications in terms of transmural injuries that we see. And the reason why it's really, really important to intervene in a very protocolized manner in these patients is because of the sequelae that follow, because of the anatomy, as you mentioned. And, you know, the patients that are going to be at risk of this are patients who have pharyngeal pouches, patients who are undergoing endoscopic ultrasound, but then also now, George, we are in an age now where we are, you know, we're pushing the boundaries of endoluminal resection, and as we, within the last 7 days, I've had an esophageal perforation, which, you know, we are managing, and I've learned more from that perforation than I have from anything I've done the last 12 months. So I think that the key here is to identify where which patients at risk, pharyngeal pouches, patients in whom you're going to dilate tight strictures, patients in whom you're going to carry out high-risk esophageal resections. And, you know, the esophagus it's really important to, when we're talking about this, George, is, you know, compared to the stomach or the colorectum, the esophagus is the thinnest part of the gastrointestinal tract. So the gap between your submucosal space and your serosa is far less than any other part of the stomach, of the GI tract. The stomach is thick, the colon is thicker, and so causing, and it's an iatrogenic or indeed a perforation during therapy is not difficult to do. And so George, one of the things that I learned quite early on in my career was sitting with surgeons doing esophagectomies or indeed thoracotomies after a perforation, was actually understanding the cavity within which the esophagus lies. And that really informs your decision making as to what you're going to do next. You saw a very nice animation there, and you know, the esophagus it starts at the back of our throat, as you know, and it then descends adjacent to your vertebral column right in the back of your chest. And the reason why this is important, George, is the mediastinal space is a very, very, very tightly packed space. You have obviously your cardiac anatomy. You have your aortic arch, and then your descending aorta, and then you have your pleural cavity. And so even the smallest amount of contamination or volume increase from gas or GI contents will have significant sequelae for the patient. And so, as that this cross-sectional image shows you, there's very little room for compensation like you have in the meat, in the peritoneum, for example, in the stomach or the pelvic cavity. And that's why it's really important to identify these things early and then shape your management based on the degree of injury.
Great. And I suppose the only other thing I would add is understand the anatomy, but also know the history. And just this week, in fact, just 2 days ago, I had to do an ERCP on a 94-year-old chap with bile duct stones. And it's only when we looked at the history that there was reference to the fact that he had a distal esophageal pouch. Now, putting a side-viewing duodenoscope down blindly in that situation, very high risk of perforation. So it was taking time to understand the patient's history that allowed us to go down with a gastroscope, put a wire in, and avoid problems. But as we're discussing, problems do happen. We are going to move on to endoscopic management because, as we've discussed, there've been huge advances actually in the last 10 years or so in what the options are. But before we do that, what about the non-endoscopic management? The do's and don'ts. If there's a big perforation, should you then pass a blind nasogastric tube? All of these things. Amidst all the anxiety of the situation, what tips would you give with respect to that?
George, I think that if anyone's listening, this part of the chat is probably the most important, because it's what you do in that moment that will ultimately shape a lot of the outcome of this patient. Forget the therapy. It's optimizing the environment. And that is, first of all, early recognition, knowing what you're looking at and recognizing the fact that you have a transmural injury or a perforation. And there's things intraprocedurally that will give you tips and tricks. If you see the muscle fibers, if you see a patient writhing around in pain, if you see stigmata of shock, and that involves things like using carbon dioxide. We go on about this, but you'll be surprised how many times we scope with trainees where they don't understand the difference between oxygen or room air and carbon dioxide. Carbon dioxide is absorbed by human tissue. And therefore, if you're pumping CO2 into a closed space, it doesn't matter. It will get absorbed. CO2, early administration of antibiotics, and also in that same vein is antifungals. So you want to cover your aerobic and anaerobic organisms, but antifungals as well. The human esophagus is not a clean part of the body. So those couple of things will be invaluable. And then also probably the third thing is know your limits, when to say, well, actually, you know what, this is not for me, and I need to go and start, what's the best thing on the shelf for me here and now? Endoscopic clips, we can all do them. Let's get them down. Is this hole small enough or big enough for me to clip it? That doesn't need to be an expert. That can be any endoscopist.
Okay, great. Well, that's a really nice link into clips, and it would be useful to know the scenarios in which we should be reaching for through the scope clips, and the scenarios in which that is not the appropriate next step. Comments.
Yeah. So, George, thank you for that. I think that's it. First of all, know your equipment. So anyone involved in endoscopy, doesn't have to be therapeutic endoscopy, needs to know the mechanics of the equipment that they have on their shelf. We are spoilt as operators now because we have a plethora of clips. So know which clips you have in your department, know the aperture of the apparatus, but also know, as importantly, the firing mechanism. So, the person next to you during this procedure is going to have as an important role as you. So your nurse needs to know what your instructions are. Close, deploy, or close, don't deploy. they are two, different clips have different mechanisms. We now have the instinct clip. We also, not on this clip, is the resolution, the Res 360, which can rotate along the 360 axis. So, without harping on about this, know your equipment, know what clip to ask for. Now, linear defects that are, less than 20 millimeters, where the mucosal membrane is been separated, they're perfect for clips. And the key here is don't start to clip the defect first. Always clip anal to oral. So start at the anal end of the defect, and the first clip you should put should be in normal mucosa, about 5 millimeters distal to the very edge of your linear defect. And the reason for that is where you're then going to begin to bring the tissue together. If you start to clip at the very center of the defect, all that's going to happen is your clip is going to oppose to only one wall of the mucosal defect and fall into the hole, or going to make the rest of your clipping procedure very, very difficult. This is a multi-band mucosectomy, very, very safe. You can see here very early recognition that all has not gone well here. So you can see actually we've got so forget what I've just said here. This is not me. This is a colleague of mine. So he's chosen to go oral to anal, but you can see what he's done. His first clip is in the normal mucosa, and you'll see how much easier that makes the rest of the clipping process. So, in the short time between the mucosectomy and this video, he's actually changed endoscopes. It took 1 minute. So what he's doing now, he's clipping. His first clip has gone into normal mucosa, and you can see how beautifully a massive hole has already become smaller. And it's to use a combination of your downward wheel, suction, the mechanics and the physics of the clip to bring the tissue together. And, within a few short steps, you have complete closure and a little bit of mediastinal contamination, which the patient will ride out with some antibiotics. And, this is what saves a patient from a 4-week hospital stay on TPN and intercostal drains.
And so the site of the perforation, clearly and we'll come on to this, that the size of the perforation may determine whether you go for clips, but the site isn't a determining factor, is that right?
Well, in the proximal esophagus, for example, where you may have a pharyngeal pouch or you may have a cervical web, the anatomy of the esophagus is important to know. You only have striated muscle up here. We've all done esophagoscopies where you see there is actually no contractility of the proximal esophagus. So your ability to get nice chunks of cirrhosis of submucosa like you did there are difficult. Those lesions those defects are very difficult to close. But also, George, there isn't much room in the neck. Above and below the clavicle, there is very, very little room. So, I've had a couple of Zenker's perforations and, over 100 diverticulotomies. I tend not to close them because I know that my clipping is not going to work. And so, you leave them open and they'll ride it out. However, further down, if you have a defect like we just saw, the other option is not a through the scope clip, but actually an over the scope clip. And, we're very lucky now because, our industry partners like Avesco and Diagmed, we have the padlock clip, we have the Avesco clip, and these allow you to, in fresh, healthy, well-perfused tissue where there's no fibrosis, ulceration, or scarring, you are able to essentially create a negative pressure due to your index finger on the bottom part of your scope to suck the tissue in and essentially create a full thickness closure with these over the scope clips. This video, unfortunately, there you go. So this is I remember this patient very well. I know we're talking about esophaguses, but this is a D1 perforation, George. This is already, someone's had an attempt here with endoscopic closure with suturing. And the poor fellow has had he's got a retroperitoneal collection, and we've gone for the over the scope clip here. The first thing to do here is obviously secure your duodenal access with a wire, just to make sure that you don't, cause gastric outlet obstruction. And then here you can see the sort of bear claw clip that I call it. Position it in a position that you get the best visibility, and then you suck in the tissue, and you can then deploy the clip. And you can see here this patient had a good outcome with a full closure of an anatomically very difficult clip. So have these on the shelf, know how to assemble them, know how to deploy them, and get some training from your reps as to how to deploy them.
Great, and a great tip about the need to suction the tissue in order to bring it into the clip. And just a word about the endoscope in this setting. Does one need to change to a therapeutic gastroscope, or can one proceed with a standard gastroscope that you may well have been using for what might have been just a bog standard diagnostic endoscopy?
Yeah, no, George, I remember being a registrar many years ago. Well, not that many years ago, but being asked, have you got the therapeutic gastroscope? Back then, it was important that was a consideration. Now it's not. We are in a position where we can put things not just down the endoscope, but we've moved away from that. We're now working around the endoscope. So you don't need, you can work with a 9.8 millimeter or even an 11 millimeter endoscope with the Avesco clip, or with endoscopic suturing, that will allow you to maintain the suction and the vision that you get with the CCDs and the smaller scopes, and deliver therapy as you've seen here. And right. This is actually a really important slide as well. Thank you for putting this up. Is there are different OTSC clips, and the OTCA, the OTSCT is probably the one that we use the most. So slightly smaller spikes, but the physics of the deployment is such that the anchoring physics allow a much tighter compression, and that just comes down to the fact that there's a smaller surface area. The bigger surface area you have, the force is dissipated over a bigger surface area. So again, a chat to have with your reps and understand a little bit about the physics of clips and where and when they might be helpful.
Brilliant. And just to say that there's more information on the GastroLearning site about these techniques and these technologies. Just say a few words about EndoLoop, because there are, I've seen you and others, advocate, the occasional role for the EndoLoop in closing perforations.
Yeah, no, George, it's worth mentioning. I think this is not for the occasional endoscopist. This is a really fidgety piece of kit. The EndoLoop historically was a device that was used to create a sort of pseudo tamponade before endoresection of pedunculated lesions. The benefit here really is in the context of using the EndoLoop as a matrix, really, to then use conventional endoscopic clipping. They are very difficult to use. As you know, the EndoLoops involve real dexterity from the operator, i.e. the nurse, to be able to open, loosen, and then deploy. But essentially what it does, George, if you can imagine a defect, you open the EndoLoop over the perimeter of the defect with a sort of 5 to 10 millimeter margin, and then you clip the EndoLoop to the normal mucosa. And then essentially once you have done that circumferentially, or at least over 270 degrees on contralateral walls, you then close the EndoLoop, so essentially inverting normal mucosa and creating closure. The benefits of this are that it is good for fresh perforations. The problem, however, is that with established perforations, your tissue will not heal. You need the tissue to be agitated in order for the regenerative process to occur. And so you need to look at things like APC or cytology brushes to rough up the tissue. And I think that's an important thing when you're coming to closure, is how is the tissue going to heal? If you have normal on normal tissue, as you know, if you cut yourself, it will take a good 14 days before that scab falls off. You can't afford that in the esophagus. So, you need to disrupt the mucosa, because it is that, it is the combination of fibrin, that healing process from disruptive tissue that will allow apposition.
Okay. Great. Now, many people will, listen to that last section and think, crikey, that all sounds complex. I'm going to be much happier in the setting of a perforation. I'm comfortable putting in fully covered esophageal stents. I want to manage esophageal perforations with a fully covered stent. So I want your comments on that. And there's an interesting question also from Kamran Mushtaq, who's saying, if you've got a really significant defect, can you use more than one OTSC clip?
Cameron, that's a great question. You can use as many clips as you want to, but the problem is once you fired your first one, it is very difficult to then get the volume of tissue that you need to give your clip apparatus the amount of tissue that you need for closure. So I personally have never tried it. I think it's quite difficult, and I think if you're looking at a second clip, OTSC clip, then you know that your initial choice of closure was perhaps you've undertreated that patient. You need to consider an alternative means.
Okay, so that takes us to fully covered SEMs. Many people confident, happy, put them in, but do they work? And should we be using them? And if so, in what scenario?
Yeah, George, there was a big discussion when the ESGE guidelines went out in I think 2 years ago on this. The problem is we are used to putting stents, whether they're fully covered, partially covered, or uncovered, in a diseased esophagus where the luminal circumference has been compromised by whatever disease has initiated your decision making. When you put a stent of any caliber into a normal caliber esophagus, it is very likely that they will migrate, especially in the esophagus, which is a pulsatile organ, and therefore in the acute setting, it really, in my opinion, doesn't have a role unless you are in a position where you can secure the proximal end of your stent with a device that will keep it in place. Fully covered stents, nitinol, they will. There is nothing allowing the tissue ingrowth. So what you need to do then, George, is if you're going to place a fully covered stent and you have the skills to do so, is then look at ways to anchor the proximal end, either with the our friends at Avesco with the stent fix device, or if you have the availability or skills within the department for someone who can use endoscopic suturing, is to suture the stent in place to allow the stent to create that tamponade. But remember, please take your stent out in 6 to 8 weeks, because tissue overgrowth will mean you will never get these things out. And you and I know from a recent patient how difficult that can be.
Yeah, 100%. So that's a really nice link into what one might call advanced techniques, suturing. Now, the endosuturing systems, are being increasingly widely used. Many endoscopists will be, uncertain about them in their own hands, probably quite rightly. They need significant training. But getting back to our original premise of the scenarios in which particular techniques are needed for esophageal perforations, where does endoscopic suturing sit?
Well, I think it sits right at the top of acute perforations. For me, it is, in fresh settings, it is a very, very good option. Now, this is a video of a patient with a bore halves presenting a week later. The important thing is, before you close the defect, George, is don't seal off a closed space without making sure it's clean. So what we've done here is actually we've gone into we actually made the perforation bigger with a Rigiflex balloon. And then what we've done is we've entered the mediastinal cavity. In the distance, you can see your left pleura. And what you can see here is this fibrin sort of dead tissue, which intercostal drains will just not reach. So you need to get in there and you need to get it all out. And the only way you can do this is if you've got an intercostal drain, because then what you do is you flood lots of water in to clear the mediastinal cavity. And this is what I was talking about. Before you suture or close, agitate the tissue. So APC here at 80 watts. And this is an example of the suturing device. So again, you can see what I'm doing here, George, is I'm starting from the oral end, from normal mucosa. This is a tricky device. It took me the best part of 12 months to get the hang of it. I do a lot of endoscopic suturing for bariatric endoscopy. In a closed space like this is tough. And there's often scenarios where I get it wrong because I just can't see. But essentially, it's getting as much normal tissue as you can. And then in your brain, having a surgical mindset that where is my suture going? Am I going to do a crisscross suture? Am I going to do a figure of 8 suture? Or am I going to do very small uninterrupted sutures? This is advanced endoscopy. And I certainly wouldn't recommend that anyone, who tries this in an acute setting, because you will do more harm than good. But is, for me, in a unit where you have access to this, can be the difference between a patient having an 8-week ITU stay and a thoracotomy and a VATS procedure, or a 2-week stay and a little bit of PN. So this was closed, and we did something called the methylene blue test. You put lots of methylene blue down, you put the intercostal drains of negative suction, and if there's no mediastinal leak, so the first methylene blue test, there was a little bit coming out of the right intercostal drain. So we went and reinforced the sutures. We did the methylene blue test again, which is basically to put methylene blue in your foot pump and basically just marinate the esophagus in liters and liters of methylene blue, put the intercostal drains on negative suction. If nothing comes out the intercostal drains, this patient probably doesn't even need a contrast swallow. They can start eating the next morning.
Great. And I mean, we could, we probably need a separate 2 hours to discuss endoscopic suturing, and
I think we should. Just a little, to gastro learning, it's a really important point. We've got the BSG guidelines on bariatric endoscopy coming on. You should do that because there's lots of interested people.
Yeah, but you need healthy tissue. You need, following the surgical maxim, you have to have healthy tissue to put sutures through, presumably.
That's correct.
Tell us about Endovac. Big perforations and other, where that sits, and tell us a bit about that.
Well, vacuum-based therapies for wound closure have been used, for many decades, whether that is, cutaneous injuries or intra-abdominal injuries. And, our surgical colleagues use that after, complex abdominal surgery. So what happens here is there is a small sponge on a string that is delivered through an endoscope. It comes out transnasally, and that sponge is placed into the defect and put on negative pressure. It needs to be changed between 48 to 72 hours. And what that negative pressure does, it basically sucks out the moisture, and a little bit like some of the topical hemostatic powders, causes a concentration of the proteinaceous mechanism that is involved in tissue healing. But it is a rigorous technique. You need to change this every 2 to 3 days. But there's no level 1 evidence on this, but the preliminary evidence is that it is very, very good. And, as you guys are always doing on gastro learning, innovation, there are now stents with negative pressure and sponges on them, which, I'm sure you will showcase on your webinar series in the next 12 months. So, that's great that industry are working with us to help us to mend these holes.
Fantastic. Great summary, Rehan. But we've actually, goodness me, that 30 minutes has rushed through. Give us 1 or 2 takeaway points as to how, within our practices, esophageal perforations will be managed better for the patient.
Yeah, I think that, be honest with yourself. Don't underdiagnose defects. If you think that something doesn't fit the norm, then interrogate it and be honest with yourself and the patient that there is a defect there, and then also know your skills, and back off when you think that this needs to go to someone else, and then also just know the different parts of the esophagus in terms of the impending gloom that may come your way, depending on where the injury is, and know your equipment.
Great. And just to press you finally, it's all very well to back off and you say, this isn't for me. I've been associated, or I've caused this perforation, but I don't have the skill set to deal with it. The worst thing, I'm sure you'd agree, in that situation is for that individual to then blindly do stuff that they really don't have the skills to do. Just briefly tell us within our network, what you've instituted to help out in that situation.
Yeah, look, George, I think that's, it's all about grounding yourself and knowing your limits as an endoscopist, but also as a clinician in terms of your decision making. And we are creatures of habit. The more you do something, the more accustomed you come to dealing with it, with your eyes closed. Is as a hub and spoke model. We in our network, thanks to my good friends and colleagues at UGI, Dr. Graham, we have a perforation center. So our network knows that if there is an esophageal injury, they will be on the phone to us early, and that's all we want. We want to know about this early so we can intervene, and I hope that will then, disseminate to other parts of the country, which hopefully it will do through things like this.
Yeah. Okay. No, I think that's a really good take-home point, because we can see the excellence and the brilliant endoscopic skills that you can bring to this. What we don't want is people going away thinking, oh my God, I'm never going to be able to do that. We need to make it clear that there are referral pathways to get these patients sorted. Rehan, we've run out of time. Thanks ever so much. We will probably get you back every week over the next 12 months to discuss suturing and everything else, but fantastic as expected. And thanks everybody for joining us. You can of course review this Gastro Live on the Gastro Learning site, and many other tricks and tips related to esophageal perforation and its management. So thanks so much, everybody, for joining us.